Frexalimab is a new drug being developed to treat multiple sclerosis with a successful phase 2 trial, now in phase 3 trials. It's completely different than any other drug used to treat MS. It is an antibody that targets CD40 ligand, or CD40L, also known as CD154, and I'll explain what this is in detail on the next slide, but in general, it blocks the activation of T lymphocytes by antigen-presenting cells such as B lymphocytes, and it's present on multiple types of immune cells, including dendritic cells, macrophages, and microglia, which are present in the central nervous system. It's being studied in other autoimmune diseases as well, such as Sjogren's syndrome, lupus, and type 1 diabetes, but it's not currently used to treat any human disease to my knowledge. In the past, similar drugs were studied in organ transplants to prevent organ transplant rejection, such as ruplimumab and toralizumab, but they were considered to be failures due to the risk of clotting events, such as the formation of blood clots like deep venous thrombosis, stroke, heart attack, that kind of thing, so they're not actually used. For technical reasons, Frexalimab may be safer in terms of the formation of blood clots, although keep in mind very few humans have actually received this drug, so we don't know for sure. So this diagram shows a normal interaction between a B cell, and it could be any antigen-presenting cell, and a T helper cell. And so this B cell sees this antigen. This is like a piece of a protein from a virus or bacteria, and it presents it to the T cell receptor, and it uses MHC2, or major histocompatibility complex 2, and a lot of the genes that increase the risk of MS are related to MHC2, for instance, HLA-DRB1 where if you have 2 copies of this allele, you have an 8-fold increased risk of MS, and then it stimulates the T cells to proliferate, and of course, in multiple sclerosis, the immune system is confused and deranged, and it's attacking self-antigens, components of myelin, as though they were foreign invaders. However, this interaction also has a co-stimulator, CD40, on the antigen-presenting cells, binds to CD40L, or CD40 ligand, and this is integral to this interaction taking place and for the T cells to proliferate. So Frexalimab binds this and sort of interferes with the interaction, hopefully preventing from T cells recognizing myelin antigens from proliferating and attacking. Of course, there may also be a risk of weakening the immune system and causing infections, so we'll have to look out for that. This presentation will focus on data in the published phase 2 trial published in the New England Journal of Medicine. This is a double-blind, randomized trial, and there are 129 participants with relapsing MS. Now, as you'll see, there is an ongoing phase 3 trial in secondary progressive multiple sclerosis, but right now there's simply no data in progressive MS whatsoever. Now, CD4 is on a lot of different antigen-presenting cells, including dendritic cells and macrophages, which are in the central nervous system and may drive so-called smoldering multiple sclerosis, so this does portend some hope for this drug in progressive MS, but there's simply no data. Anyways, this study, in order to recruit people to the trial, they gave 80% of the participants the drug and only 20% placebo. So it was 4-4-2 randomization. So 40% got the IV version of the drug, Frexalimab, 1,200 milligrams every 4 weeks, and they gave a loading dose of 1,800 milligrams just so higher doses would be in the body right away, because this is a very short trial, only 3 months. Another 40% got the subcutaneous version, 300 milligrams subcutaneous every 2 weeks. So if this formulation got approved, you would give yourself an injection in the stomach or the thigh every 2 weeks, and they gave a loading dose or initial dose of 600 milligrams subcutaneous. And then they had 2 placebo groups, one getting an IV placebo and another group getting the subcutaneous placebo, or else everyone would be unblinded. And together there were 26 people getting the placebo. The primary outcome of the study was new gadolinium enhancing or active lesions, which look like this on MRI scans. And you can see the high dose Frexalimab 1200 milligram IV dose, there were only 0.2 new lesions on average. For the subcutaneous group, it was 0.3 versus 1.4 for placebo. So an obvious and statistically significant difference. It works out to an 89% reduction for the higher dose IV group. Of course, 1200 milligrams IV every 4 weeks is twice as much as 300 milligrams every 2 weeks, and the lower dose yielded only a 79% reduction. Also, the higher dose after 24 weeks, 96% of people had 0 new enhancing lesions. A couple things to note from this. One, the higher dose is probably better. And the second thing, although 89% seems like a dramatic reduction, it's not necessarily as good as the truly highly effective disease-modifying therapies. For instance, studies on Kesimpta showed an almost 100% reduction in active lesions. Even moderately effective disease-modifying therapies such as Tecfidera had an 80 to 90% reduction in active lesions in clinical trials. However, this is a short study. Often there's a therapeutic lag where drugs aren't effective immediately, so maybe it would be more effective over time. For newer enlarging T2 lesions, it's the same thing, 92% reduction with the higher dose IV group and only 86% reduction, a little bit less with the lower dose subcutaneous group relative to placebo. For relapses, there were no clear differences. The placebo group, only 1 out of 26 people had a relapse. 2 out of 51 had an attack with the lower dose subcutaneous group, and 0 out of 52 with the higher dose IV group. I do note there's a slight trend towards fewer relapses with Frexalimab. 1 out of 26 is more than 2 out of 103, but obviously not statistically significant. They also looked at a biomarker for central nervous system injury called serum neurofilament light chain. It's a blood test that correlates with multiple sclerosis flares and worsening disability progression. It doesn't mean much for an individual as there's a lot of day-to-day and individual variation, but in populations of people, it does correlate with worsening disability. And if you look at the placebo group, for instance, at baseline, the mean was 12.33, and it increased by the end of the study to 13.75, whereas in the high-dose IV Frexalimab group, it decreased from 12.04 to 10.29, which works out to a 24% reduction, and a more modest 18% reduction in the lower dose subcutaneous group. Not all that impressive, but it is an objective sign of decreased central nervous system injury. This is another biomarker, CXCL13, which is a marker of inflammation in the cell. And with the high dose IV group, there was a 21% reduction compared to placebo. And with the lower dose subcutaneous group, there was an even greater reduction of 30%. It's hard to measure differences in disability. This is only a 3-month study, but they did use a patient-reported outcome. This is the multiple sclerosis impact scale, essentially a survey, and there's a physical impact scale and a psychological impact scale, basically how much does MS affect your life. And they found that with the higher dose IV group, there was improvement in the physical impact component of the scale, a 7.9 point difference on average, and this is a 20 to 100 scale, so that would be clinically significant in my opinion, but of course they're cherry picking. They didn't show the data on the psychological impact scale, and with the subcutaneous group, I presume there were no statistically significant differences. What about side effects? Well, the good news is there were no severe side effects, no clotting events out of 129 people, not a single clotting event over the course of the study, and no weird opportunistic infections. Now, this was done when COVID-19 was prevalent, and there were cases of COVID, and all 5 of them were in the treatment group, specifically in the lower dose subcutaneous group. About 10% of people got COVID-19 versus 0 getting placebo and 0 in the higher dose group. And that could be significant, though keep in mind 80% of the people in the study were randomized to get some form of the drug. But we'll have to watch out for infections. All 5 of these people had mild or moderate COVID-19. No one had a severe case of COVID-19. Another potential side effect was headache. 6% of people reported headache with the higher dose IV group versus 2% with the lower dose subcutaneous group, and 0 people getting placebo, although headaches are fairly prevalent in the general population, so it's hard to say, but headache is a potential side effect of this drug. And we'll learn more about Frexalimab in the upcoming years as there's ongoing research. One study is the extension phase of the phase 2 trial I just showed you. Is Frexalimab actually safer than first-generation anti-CD40L agents over the long term, or does it cause clotting events? There are also phase 3 randomized trials. One is this study in relapsing MS. This is actually two simultaneous identical studies, and there's one shared protocol, and it's a comparison of Frexalimab against Aubagio, a lower efficacy pill for multiple sclerosis. In my personal opinion, for Frexalimab to be clinically useful in relapsing MS, it really has to beat Aubagio. It can't just be safe. It has to be more effective than Aubagio. They're looking for people aged 18 to 55, looking for 1,400 participants total between the two phase 3 trials. I also noticed my mentor, Dr. Regina Berkovich, formerly at USC, now in private practice, I believe, is recruiting for both this relapsing MS trial and the progressive MS trial in the West Hollywood area. So you can definitely contact her if you're in my area and interested in the study. There's also a progressive MS trial, a secondary progressive multiple sclerosis trial against placebo, ages 18 to 60, and you can have an expanded disability status scale or level of disability up to 6.5. That means even if you walk with a walker, you still could get into this study, and that's important as we need more data in older people with progressive MS with more significant disability. As I said, CD40 is present even on macrophages and microglia and may contribute to smoldering multiple sclerosis, so even if the drug is less effective than, say, B-cell depleters like rituximab, Ocrevus, Briumvi, Kesimpta, and relapsing MS, it could actually be more effective and safer in progressive MS. Very possible, in my opinion. They want 858 participants, and the study will be completed around late 2026. So to summarize, I do think Frexalimab works. I don't necessarily think it's as effective as the higher efficacy disease-modifying therapies, such as B-cell depleters in relapsing MS, at least. As I pointed out, the reduction in gadolinium-enhancing lesions is actually less than many of those agents, though it could be more effective and safer in progressive MS. We just don't know. It's good that there were no safety signals in the phase 2 trials, but it's just not enough people, not enough time. We don't know about the risk of clotting events and infections, so there is some concern there. But I'd be interested to know if you are excited about this new class of disease-modifying therapies and if it shows significant promise, and let me know if you have suggestions for other videos.